Nós temos agora um períodozinho para perguntas. Se alguém tiver alguma pergunta para qualquer uma dessas palestras dessa mesa. A gente tem um microfone, outro não? Tem. Alguma pergunta? Bom, eu vou fazer uma pergunta, começando pela... Tem uma pergunta? Aqui.
Sim. Eu gostaria de perguntar para o Hélio sobre a ureterocele invertida, que você fez uma imagem muito bonita. Mas isso não demonstra já que esse meato ureteral ou esse ureter está dilatado? Se você fizer uma fulguração, você vai ter refluxo, já me indica um pior prognóstico do tratamento endoscópico?
Na verdade, sim. Quando você tem uma ureterocele que everte, como aquela que a gente mostrou, isso significa que o orifício na parede da bexiga é grande e o suporte de musculatura atrás dessa ureterocele não é tão bom assim. E isso normalmente faz com que, após a punção, haja uma incidência um pouco maior de refluxo, dito refluxo iatrogênico. Então, é um dos fatores que fazem com que o prognóstico do tratamento endoscópico puro fique um pouco prejudicado. Ou seja, mesmo nas ureteroceles intravesicais, como aquela, se existe a eversão da ureterocele, você vai ter um prognóstico um pouco pior. E isso faz com que você tenha mais cuidado ainda no acompanhamento desses pacientes. E no caso de ureteroceles intravesicais, o que a gente faz é acompanhá-las e, se elas tinham esse aspecto de eversão já no diagnóstico, isso faz com que nós sejamos um pouco mais agressivos, digamos assim, em indicar um tratamento cirúrgico posteriormente, se esses pacientes têm refluxo vésico-ureteral. Porque, normalmente, o que a gente faz é, depois da punção de uma ureterocele, mesmo intravesical, e especialmente intravesical, se existe refluxo para dentro da ureterocele, a conduta é aguardar, porque, com o passar do tempo, esses refluxos também desaparecem. Agora, num caso como aquele, se a ureterocele everte, esse refluxo vai desaparecer menos facilmente. E você pode indicar uma cirurgia mais precocemente para corrigir cirurgicamente o defeito.
Vamos aproveitar os nossos amigos aqui. We're talking about you want to comment? You seen that case where the ureterocele? Yes. The question is, how would you manage that? Would you use a back B or you would indicate a surgery?
Me, I can further the question, because a bad case, why you proceed twice a surgery, endoscopic and or reimplantation? Why don't do direct reimplantation ureter because it's very wide?
Yeah, so just to clarify, the question is why do two different staged procedure versus... So I actually would do similar, and I would do the incision of your ureterocele. I started using the laser. Actually, we were just talking about that. And I do that very young, so at 1 month, and we use spinal, and so that obviates general anesthesia. And when you look at that big defect, you know you're coming back to do bladder surgery. And so then I push that off to 18 months, and then at least with the upper pole, you give some chance that maybe you won't have to taper or taper as much. And so that's one reason that I do it that way. And of course there are many ways to do it, and you could combine and do it at probably 12 months would be the youngest I would do something, knowing that you're going to probably have to taper the upper pole if you're preserving it. The other reason I do it is sometimes the upper pole doesn't drain, and so in that situation I would do an upper pole heminephrectomy, and that would be the reason, and so that's kind of my approach. So.
I mean, I agree. I think that what you're describing with the laser, I've seen that reported as a watering can approach, so that you instead of making a bigger hole, you're making multiple tiny punctate areas. The one concern I have with the laser is that I think one of the benefits, I use a bug bee, and I think that the reason I like a bug bee is because you have a known thermal ring around your area of perforation. And I think the challenges that I have sometimes is you have a thick ureter seal, and sometimes we see these things recur. And I think a bug bee, unlike a laser, I think you're going to get a larger area of thermal damage and you get a nicer hole. But I think that with the watering can, that's how you solve it, is that you make multiple small holes.
And just to comment for that technique, I assure that it decompresses, as you're watching it, yes. in terms of that.
Alguma pergunta? Vamos continuar então a discussão, aproveitando os nossos convidados, né? Do you use laser in PUV cases also? No.
I was just commenting on that. I guess for the urethra, at the age you're ablating the valves, I really like the cold sickle blade. I like it for two reasons. One is my colleague's right. You have a controlled area of thermal distribution when you're using the bug bee, but in that urethra at that age, I think there is some potential risk there if you're using a bug bee in the urethra, or the laser for that matter. So that's why I use cold. I like the sickle. The second reason is that it's the flow of where the urine's going, and so it allows you to put it at 5 or 7 and then pull. And then at the end, I'll flip it up to 12, and then I'll incise right where I can see through to see the blade. And so that's the other reason I like that. It gives me what I want to incise at 12 o'clock, which again is not a lot, but some of those kids, if you look at recurrences, that's where the recurrence typically can be found, is at the 12 o'clock, and that's why I use that technique.
We're just talking between ourselves earlier about techniques, and even though it's very much non-technologic, I was trained to use the Whittaker hook, and I don't even think they're made anymore. And I know they're, again, with micro instrumentation, really unnecessary, and they can be dangerous because I have seen them where the insulation on the hook will be lost. But I remember back when I was a fellow using them and just enjoying it. It was so simple. And I think sometimes when you go forward with technology, sometimes you make things harder, and I'm not sure any better.
What is the size of your scope when you use a resector scope?
So for the valve, it's the I guess 8.5, yeah. And then I have on occasion, if it's a very small urethra, the options are to wait, do a vesicostomy, or you can fashion a three French catheter has a wire, and you can fashion that wire into a hook, and that's the only situation where I would use thermal energy is you're at the point where you can only get a cystoscope down that is much smaller than 8.5, and maybe a neonatal scope, but you can get that wire through, and if you insulate it with the 3 French catheter, then you can obviate a vesicostomy, which would be your only other option, or leaving a catheter in for a long period of time for the premature valve patient. I think it's a difficult challenge because here I'm going back on my thermal energy comment, but the options are catheter or vesicostomy in that child, and if you have an infection with long-term catheter drainage, sometimes that's worse than the risk of minor risk of having some urethral thermal energy injury.
The scope that I like using is they're always changing names, but it was the old MRO 715 ACMI scope. And the reason I like this scope is it is 7.7 French, and I think that there's many patients where you're not going to get an 8 or 8.5. 7.7 is beautiful. It's a abbreviated pediatric ureter scope, and the great thing about it is that it has a 5 French working channel. So there, again, you're committed to using a bug bee, but you can put a nice bug bee down it. It's got great flow, And I think you're going to be able to do a lot of valve ablations that you wouldn't be able to do with an 8 French scope.
What's the role of the vesicostomy in treating posterior urethral valve? Because on the other side, what you mentioned, you were afraid to use energy, but on the other side, to do a vesicostomy. So what's the good indication for a vesicostomy in posterior urethral valve?
Well, it's interesting. I'm one that ablates early, and when I moved to Richmond, we have very aggressive nephrologists that I think part of it comes into a conversation of shared decision making. And kids that have significant upper tract dilation that's getting worse and have very renal reserve is low, I think that's an option to divert them. And again, I'm not a big fan of that, but I would say the patient, and it's rare, that has creatinine doesn't nadir below 1, and you have massive ureteral dilation, and those are kids that I think ablating and allowing them to void might not be the best option. I think the fear of vesicostomy, you ruin the bladder, the level of evidence for that is very poor, and there's no question those kids do better from an upper tract standpoint when you do a vesicostomy. There's no if you select it properly. And so I would say it's that rare patient that has clear renal insufficiencies, defined as a creatinine greater than 1, that has increasing ureteral dilation. And the third would be patients that have a compliance issue, meaning that they might not come back for their studies and ultrasounds. At least you kind of know they're safe. Now, the question I'll put back to you, in terms of if you're diverting, would you do ureterostomies versus a vesicostomy? Because that's something that I do struggle with, because I do think you need urine in the bladder. And even though you have a vesicostomy and it's decompressed, at least the bladder is filling to some degree and emptying. I think if you completely divert the bladder, then you might have a different situation. And Greg, I'll let you answer, and then.
I think that I'm not afraid to use a vesicostomy, and I think that your comment about the deterioration of the bladder with a vesicostomy, I think, is overrated. And I think that you always do have a fair amount. In fact, that can be one of the challenges with the vesicostomy, is that you'll do it, and then you'll get an ultrasound, and you'll say, "Wow, there's still 20 or 30 cc's." The bladder is still cycling, so I think I'm not afraid to use it. I would say that if I had a child that is 35 weeks or younger, I would just automatically go to the vesicostomy. I think, but once they're older than that, I would assess that there was no growth retardation. I would just plan on doing primary valve ablation. Certainly, though, if I had a patient that I did valve ablation on and there was rising creatinine afterwards, then it would be a challenge to determine in my mind whether I should go to the ureterostomy or the vesicostomy. I think the ureterostomy might be if the child is sick, that may be the more surefire way of solving the problem.
Kids that you do that in, I've gravitated doing an upper tract, because some of those kids, it's a temporary phenomenon, and then you can obviate a reimplant because you can just make it a UPJ repair, and it's a little bit easier than if you do a distal ureterostomy. Then you're going to reimplant into a bladder that's not normal, and so that's something that they have these different techniques now that are well described that I don't have to get into, but I want to know your position.
There are cases that you have a wild dilatation, but it's not representing obstruction. So you'll never know if you are treating something that's necessary to be treated, and you will add unnecessary further surgery. That's the main issue. Yeah. But I always tend to do vesicostomy, not higher diversion.
We have a doctor who now retired, but we have a lot of his patients, and he he went high on a lot of his patients. And let me tell you something, we have one in particular that is extremely challenging. My partner actually ended up, he had to reimplant him, but ultimately this kid's got a very long length stricture related to that diversion that he did early on. And it's just a challenge.
And what I'm speaking to is a failed, not failed, but a vesicostomy is not draining everything. And you pick one, and you're doing one side. And I, in essence, bring the renal pelvis out. So then you're just closing that back up.
Some patients during the puberty develop a bladder valve, dysfunction of the bladder. How you manage these kids?
Yeah. Yeah. So that valve bladder syndrome, is that what you're saying? Yeah. So again, in the U.S., at least in my experience, I've been at 3 different medical centers, and the more heavily involved the nephrologists are, I find myself more involved in the bladder dynamics and urodynamics and those sorts of things. So we start those kids early on, cathing, if they show signs of failure to decompress their upper tracts. And when those kids get to puberty, they're already those kids are primed of the need for intermittent catheterization. The need for augmentation is variable. I think if you get to that point, that they have a big system that's it's synonymous to BPH and deterioration of the bladder in the male, and so it's a reservoir that just needs to be intermittently cathed. We do offer, because of sensate urethra, Monty or catheterizable channel as an option. I don't think it's mandatory, but it does appear to improve compliance. We do have some families that culturally they cannot catheterize the urethra, and they can catheterize from above, and so that's when you're down that path, I think it's reasonable to offer that. Because it improves quality of life, and from a practical standpoint, they can cath in an environment that they can just pull up their shirt and catheterize instead of going through the penis, and I think long term that's probably better. I'm sorry. In those kids, we do have overnight catheterization, and that would be the other benefit of the Mitrofanov, is that it facilitates that in terms of decompression.
I think overnight catheterization we start very early, and then ditropan, just because it improves the functional bladder capacity. I think you see an improvement with those patients. And the other thing is to set the expectations. As we all know, there's the experience is generally that the bladder improves, and I think that a lot of it is sort of nursing the patient through that period so that they can hopefully have improvement, and that you don't have to do an augment. I would say, in my own experience, I've never had to augment any of those patients.
Yeah, I was just going to say that valve bladder syndrome child is, in some ways, could represent a failure of management early on in terms of aggressive bladder therapy, and that's one thought there as well.
Eu queria aproveitar o Rafael, está online ainda. Rafael, você quer fazer algum comentário em relação a essa discussão? Você fez essa parte, falou sobre a válvula, né?
A mensagem que eu queria deixar é exatamente o que já foi comentado, de que a gente tem um papel fundamental no tratamento da bexiga de válvula, da disfunção de válvula. Talvez seja onde a gente consiga evitar esse dano a mais, além do dano renal que esses pacientes perderam no período uterino. Então, a gente também aqui trata de forma bem intensiva essa disfunção da válvula na bexiga.
Bom, obrigado. A gente tem um intervalo agora e depois retornamos às 10h30.